A warm welcome to today's talk. It's Wednesday the 4th of August today. Now I want to look at the new vaccination recommendations for 16 and 17 year olds from the UK and look at the pros and cons of that and report what people are saying. But just before we do that, I want to say something about vaccine prices. Now, I believe this was first published in the Financial Times. I actually picked it up from a report in the Daily Telegraph. European Union supply contract. We now believe that one Pfizer shot on this new contract is €19.50, which is £16.65, which I guess is about $20 per shot. And of course, everyone needs 2 shots. So fairly expensive, up from €15.50 we believe on the previous contract. One Moderna shot, we believe, costs £18.30, so it's even more expensive for the Moderna. So the Moderna keeps its place as the most expensive vaccine that we are using. And we believe that's up from about £16 in the first deal. Now, this really is a lot of money. This is I consider this to be too much. Let's just bear in mind that, in fact, I was just working on a slide on this. Now, I think I'll just flash it up for you. So the Biden administration, this is just some work I was doing on something else, but Biden administration, $3.2 billion for the discovery and development and manufacture of antiviral medicines they've given. So the pharmaceutical people have got $3.2 billion out of that. COVID-19 and other potential pandemic viruses, of course, they want to find out and potentially mitigate against future viruses. That makes sense. Apparently, they've committed $1.2 billion to buy 1.7 million doses of molnupiravir, and they're considering other antivirals that are currently under development under trade names from ITA and Pfizer. But according to the Congressional Research Service, vaccine development, the pharmaceutical companies or the US administration, Operation Warp Speed, largely under the previous administration, have already given between 18 and 23 billion pounds. So billion dollars. So this is really quite staggering amounts of money that are being talked about here. And as we just say, that the prices now seem to have gone up again for the European contracts. So one would assume that there's quite large sums of money being made here. And I'll leave you to decide on how ethical you think that is. Now, the UK Joint Committee on Vaccination and Immunisation, JCVI, 16 and 17 year olds in the UK will be offered a first dose soon. Now, we don't know when they're going to be offered a second dose. This is just the first dose that we're talking about now. So when will we be offered a second dose? Don't know yet. Hasn't been decided yet. I would imagine, from the data as I understand it, it's probably going to be about 8 weeks between the doses to optimise the immune function. And part of the reason that the immunity is not as good as we would like in the United States and probably some other countries is because the doses were too close together. We believe the efficacy is increased with a bigger dose, pretty well regardless of with a bigger time gap in between, pretty well regardless of the vaccine. Anyway, 1.4 million 16 and 17 year olds will become eligible. Professor Jonathan Van-Tam, Deputy Chief Medical Officer, is very excited. We have the supply, and I'm expecting this to start in a very short number of weeks indeed, so he wants to get going. There's no time to waste in getting on with this. I want us to proceed as fast as is practically possible. And the only one that's authorised for this age group is the Pfizer-BioNTech for 16 and 17 year olds in the UK. Now, this is not new on a global basis. So routinely vaccinating children over 12, the United States have been doing it since May. France, Ireland, Italy, Brazil, Japan, Israel and Hong Kong are already vaccinating young people. So, of course, the key issue is vaccine safety, isn't it? This is really the key issue. Is this going to give more benefit to young people than harm? So that's what we want to look at now. So this is a direct quote from the government website, which you can click on there and you can check it all out for yourself. The Pfizer-BioNTech vaccine is administered via intramuscular injection, usually in the upper arm, they say. But of course, in my view, they don't know whether it's given into a muscle or not, because we don't aspirate the injections to see, because it could be in a vessel. Why this has not changed, why this has been ignored, I have no idea. Now, I'm just going to read you briefly a report from Barbara in South Africa, who's reported to us before. So today Barbara's received a vaccine. I'm delighted for you, Barbara. Excellent. It was Johnson & Johnson. You got it at work, Nelson Mandela University. Good stuff. Right. I asked the nurse if she aspirated, and she said yes, of course, and told me exactly why it's important to prevent inadvertent intravascular administration. We had a long chat about it, and she was shocked to hear that in the UK and other places, aspiration isn't being done. She said that in South Africa, it's absolutely part of nurse training. So I told her I was proud of South African nurses, and rightly so. And Barbara's arm was a little sore, feeling a bit sleepy, but otherwise fine. So delighted to hear you have that protection, Barbara. And hopefully you had the Johnson & Johnson, so hopefully just one dose of that. Until a booster might be required at some point in the future, depending on your guidelines. So there you go. I mean, see, my thinking is that if the vaccine goes into the muscle, which of course the vast majority do, but if you don't aspirate, you don't know for sure. You haven't got X-ray eyes, you can't see. So could that mean that a higher dose of the antigen goes into the blood? Well, yes, it would. Does the blood circulate around the whole body? Yes, it does, including going back to the heart. So that's my issue. I'd much rather have a slightly inflamed muscle in my arm than an inflamed organ anywhere else. So why this is not being addressed, it just seems to be a national and an international blind spot as far as I can see. But hey, this is what the governing bodies are saying. Trust issues come to mind, but there we go. The most frequent reaction in age 12 to 17-year-olds, injection site, pain, fever, headache, okay, but generally mild, self-limiting, short-lived, 1 to 2 days, so nothing too untoward there. Now, the FDA have put forward data on pericarditis and myocarditis. Now, click on that for yourself, and there's lots of sublinks there. But I think we know what this is now. So the heart wall, if you get a heart and slice it, you've got the endocardium inside, a nice smooth layer for the blood to flow through smoothly. Then you've got the contractile muscle, the myocardium. Then on the outside you've got it's actually a two smooth layers, and then a tough fibrous layer around the outside called the pericardial sac, so the pericardium. So inflammation of the myocardium, the muscle of the heart, is myocarditis. Inflammation of the covering around the outside of the heart is pericarditis, and of course neither of these we want. So what is the likelihood of this? Well, we know this is a feature of the messenger RNA viruses. So this is information from the website in the States. Onset of symptoms within a few days after vaccination, typically, so it's just a few days. Particularly following the second dose. Clinical features to watch out for: chest pain, shortness of breath, feelings of having a fast beating heart, fluttering, or a pounding heart, what we call palpitations, that you can feel your heart. You're aware of your heart beating and you can feel it beating in your chest. Now, I think it would be a good idea to advise young people especially to abstain from sports and vigorous exercise for a week after their second dose of vaccine, especially. And personally, I would advise it after both doses of vaccine. That doesn't seem to be part of the protocol in the UK, but it would seem a good idea to me. But of course, it's absolutely essential if anyone does develop chest pain, shortness of breath, or basically if they don't feel right, get to the doctors immediately. Get medical attention immediately. Would be absolutely critical, and certainly do no exercise whatsoever until you've taken a medical opinion. So that would be the thing that we were worried about. Pfizer-BioNTech and the Moderna vaccine, CDC and FDA data from the States. They say that these are extremely rare adverse reactions and have been more frequent shortly after the second dose, and in younger individuals, and more common in males. Now, what I've never seen anyone do is compare an analysis of the side effect profile of the like the Oxford AstraZeneca vaccine or the Janssen Johnson & Johnson, the adenovirus vector vaccines, against the mRNA vaccines, the Pfizer and the Moderna, in young women. Because, or rather, giving those to young men, because it's young men that are more prone to getting the pericarditis. So, would it be safer to give young men an adenovirus vector vaccine and give young women an mRNA vaccine? No one seems to have commented on that. I haven't seen a comparative analysis on that. If you've seen one, let me know. That would be interesting, but we don't know. So, but we do know it's younger. We know it's more common in males, but there doesn't seem to be any suggestion that young men are offered an alternative type of vaccine. So, there you go. That's where we are. Apparently, this data, I think this is the CDC data, 60 cases of this heart inflammation per million doses of vaccine given, mostly 6 or 7 times more common after the second dose. Now, when you say 60 per million, it doesn't sound a lot. But I've worked that out at 1 in 16,666.6 or something like that. And that means if we vaccinate the 1.4 million eligible young people in the UK, then according to that data, according to the US data, we could expect about 84 cases. Which doesn't sound ideal to me. Now, the mechanism of action underlying these rare events is not currently known, direct quote. Israel and the United States have reported most cases, but there again, the reporting systems in Israel and the United States are both particularly good. Maybe other countries have underreported. Now, they say this is what's called a milder phenotype. In other words, it expresses itself typically as a pretty mild condition, which is reassuring. And they also say the vast majority recovering swiftly from the acute episode compared to the more typical cases of myocarditis. Now, myocarditis, more typically, inflammation of the heart muscle is more typically caused by a virus or a toxin, more commonly a virus. And the thing about viral myocarditis is it can cause permanent damage to the myocardium, and that can lead to heart failure. And in fact, when I worked on coronary care, viral myocarditis, a virus called Coxsackie virus, was the most common indication for heart transplantation. But they're saying this is not like that at all. This is mild and transitory in the vast majority of cases. It's not like viral myocarditis. So that's what they're saying. Vast majority recovering swiftly. Now, a vast majority, we don't know what that means. At least I don't know what that means. I couldn't find out what that meant. I mean, the vast majority means the vast majority, but I would much prefer to see that in numerical terms. But we do believe it's small and we do believe they're mild. So we'll leave it there. That's what we know. Now, compare that against the benefits of vaccination. Secondary and school-aged children in England in early July, antibody positivity was about 40%. Interesting. So this means, because of course this age group essentially weren't vaccinated, very few had particular at-risk conditions or at-risk home circumstances. So school-aged children in England, as of early July, we must assume that 40% of them have been naturally exposed to the virus, therefore have some natural degree of immunity. So the sort of immunity of that subdivision of the herd, if you like, the community immunity there is about 40%. Presumably, if they have antibodies, they'll have some level of immunity. And if they've got antibodies, they've probably generated some memory B and T cell response as well. So 40%, interesting, just from natural infection. England, February 20 to March 2021. So that's February 20 to March 2021, that period. 61 children and young people died after testing positive in England during that 12, 13 month period. But of these, unfortunately, quite a few would have died anyway. They estimate the actual deaths from acute infection of SARS coronavirus 2 was 22 and 3 from PIMS. Now, this is what they're now calling PIMS. Paediatric multisystem inflammatory syndrome. But PIMS, I suppose, sounds like a drink or something, so it's easier to remember. PMIS would be not easy to remember. So that's what they seem to be calling it now, paediatric multisystem inflammatory syndrome, which of course we've looked at. occurring after infection. So that equals a total of 25 children and young people whose deaths are attributable to COVID-19 in England during that period of time. Not a small number, really. I mean, 25 children, they're all pretty precious, the children and young people. But that gives a mortality of 2 per million for the 12 million children and young people living in England. So overall, the mortality has been low, 2 per million for the over 12 million living here. Survival rate after testing positive, 99.995% in children and young people. Second wave hospitalisation rate, though, the second wave hospitalisation was 100 to 400 per million. So quite a few young people hospitalised. They had a pretty rough time, quite a few of them. And the ones at particular risk, children and young people with severe neurodisabilities, Down's syndrome, trisomy 21 syndrome sometimes, underlying conditions resulting in immunosuppression and severe learning disabilities. So these are the children at particular risk, and of course quite a few of these have been vaccinated now already. So they are at particular risk, but still the risk to other children of hospitalisation is still there. March 2020 to July that should be July 2021, sorry about that. March 2020 to July 2021, 449 cases of PIMS in persons under the age of 16. So 449 cases of paediatric multisystem inflammatory syndrome. 44% of those were admitted to paediatric intensive care. So the children and young people that are getting this are tending to be quite sick. So this is what we're balancing these risks against. Overall case fatality ratio during that period for children and young people that actually got the paediatric multisystem inflammatory syndrome was 1.1. Of course, it was the vast minority that got the PIMS in the first place. Now, the other risk is long COVID, of course. Existing studies suggest that longer term, and they say greater than 8 week symptoms following SARS coronavirus 2 infection occurs in 1 to 10% of persons after COVID-19. Most of the studies show that it's like typically 1, 2, 3%, and a lot of people take that as being over 12 weeks as well, but that's what this data is giving. So 1, 2, 3, 4% typically people getting long COVID. Young people, it's going to be less, but it does mean that 1 or 2 or even 3% of young people could get longer symptoms, which would be good to avoid. So we've got the risk of a longer COVID or even a long COVID. Some children, of course, do have long COVID for months, even more than a year, although a very small minority. So it'd be good and we don't know for sure, of course, that vaccine protects against this, but it's reasonable to assume that it would. And we've got the slightly more worrying cases of PIMS and the terrible cases of the 25 deaths. So they're the sort of things that we're weighing up against one thing and another. And another point that they do make in the UK literature is avoiding school and class-based measures, which they're indicating will promote mental health in children. And the UK JCVI data is also saying benefits to adults is highly uncertain because, of course, by the time the children are vaccinated and the young people are vaccinated and it becomes effective, which is going to be in quite a few months' time. So if they have the first jab even in the next couple of weeks, then another 6, 7, 8 weeks after that, then another 3 weeks to get the second jab, then another 3 weeks after that before they get significant cover. By that time, all adults who want to certainly will have been vaccinated. So they're the risks and benefits. I am not coming down on one side or the other. The choice will be up to the young person themselves. It will be entirely their choice. Now, just briefly, cases in the UK up a bit today. 29,000 today as opposed to 21,000 official cases yesterday. Still, though, the trend isn't anything like as bad as we had feared in the UK. We've seen the cases went down for 7 days consecutively, then they went up for a couple of days, then they went down for 5 days consecutively. And people are surprised that the cases are as low, but delighted. Hospitalizations also down a little bit today. I think there were 700 and something today. United States is more concerning where cases and hospitalizations and deaths does continue to rise, which we looked at yesterday, and we'll probably be looking at again fairly soon. Now, I was going to do this report on alcohol consumption during lockdown, but I think we'll leave that till tomorrow because I think that's probably about enough for today. And I think that's all we wanted to say. So that's the information. All the obviously, if you're a young person watching yourself, or if you're a parent or any interested person, all of these links taking you straight to the primary source information, the best information that we have, is in the description. I always put the full links in the description, and you can research it directly yourself, and you can come to your own risk-benefit analysis, given that the data there is pretty transparent. So that is us for today. Thank you, of course, for watching.